fall quarter of your first quarter of dental school. So I assume that that has flown by pretty quickly, and you're getting all geared up for closing out the quarter in good stead. So thanks a lot, everyone, for showing up and being here. And today I'm going to try to wrap it up a little bit with a session entitled Toward Better Health and a Better Healthcare System, because ultimately, better health is what people are seeking out of a healthcare system. And this session will actually be uh, a mix of some new material, but also I'll try to layer in a few little reminders of material that we've covered along the way this quarter, or actually, it's really only a part of a quarter that we get for this course. But so we'll start out with a real quick, broad overview of the U.S. healthcare system. We spent some time looking at organization and financing of healthcare in the U.S. We'll get some various perspectives on what's wrong with the U.S. healthcare system, as well as some examples, a couple of examples that I find particularly interesting about the one physician's efforts to address system problems. And I think ultimately it's sort of natural for in a career progression to start out and to really get into the trench and understand. First, you have to become some type of a healthcare provider. If you're in the health professions, then you get some experience in one or more multiple settings. You get some experience. You master generally the day-to-day sort of technical aspects of things, while always trying to incorporate new information that's coming in increasingly in a rapid pace. Uh, and at some point in time, it's pretty common to sort of reflect on what's going on around you and what kind of a difference you're making, and then perhaps get involved in some broader efforts. And so there's a couple of examples in here, both from medicine and from dentistry, that I've tried to put into in this particular session. We'll look at a framework for improving quality, and again, a couple of examples that come out of the Institute for Healthcare Improvement, and something called the Triple Aim. We don't cover that in any depth in this course. It's actually covered in a course that I'm doing also this quarter for fourth year students on quality improvement. But I think it's important, if we're going to talk about moving toward a better healthcare system, understanding some of the approaches that are used to move toward that healthcare system. Then we'll also look at a couple of examples about or reflections on making healthcare more effective and accessible, because we talked about disparities and we talked about the impact of social determinants of health and a lot of those kinds of things in the course. And then we'll wind up with a couple of examples related to some system issues we have with the current dental care system. And then again, an individual dentist sort of rethinking about what's the role of dentistry and oral health care, and the role for dentists. So that's the plan for the day. I will mention that I got quite a few videos in this particular session. I've tried to sprinkle in some videos along the way in some of the other sessions, because I know, just listening to one person speak, one voice, uh, gets a bit old. Um, so we try to freshen it up a little bit with some videos or other media formats during the course of the presentations. At least I was planning on doing that anyway for this particular session, but came upon this over the weekend. This pyramid that shows that a lecture can be a very passive type of a situation. Back when we were doing in-person sessions, I at least would try to draw students out and get some discussion and flowing within the course of a class. But with Zoom, that's possible, but it takes a little more structure. Reading materials. There are assignments, and you read materials, and and you get a bit more. You see some type of media. Apparently, that has a way of triggering thinking processes in your brain, hopefully, even on a Monday morning, and maybe get you to thinking about same material a little different way. If we can do any kind of demonstration, that builds it up. And if we can have a discussion, that'll give us quite a ways along on this so-called learning pyramid and help with your retention. So as I say at the top, choice is yours. I will try to pause after um, each slide that has the videos on it and just see if anybody has any thoughts or reflections, and don't hesitate to voice your opinions. These A lot of what's going on in any kind of change, and particularly something as complex as healthcare, is going to rely on opinions initially. Over time, tested by evidence and scientific processes. But your opinion, even at this early stage of your career, is important. So don't hesitate. And then ultimately, um, the theory says that I'll at least retain a fair amount of this information, at least for a while, because I'm doing the teaching. But over time, you'll be the teachers as well, both to your patients and to others. So that's going to be the approach. Okay. So we're going to start off with a quick little video here, overview of the U.S. healthcare system. Hopefully, you find this both educational and a little entertaining.
Whenever I talk about health policy, especially as we try to reform it here in the United States, I get a lot of requests to talk about how exactly healthcare works in different countries. Lots of countries. It's not that I don't think those are great questions. I do. It's that summarizing a healthcare system in just a few minutes isn't easy. But we don't shirk from difficult tasks here, and so we're going to start tackling countries, one by one, starting with the United States, here on Healthcare Triage. The United States healthcare system is similar to that of many other countries in that it's a mixture of both private and public components. Let's start with the easy stuff. Almost all care is provided for by the private sector. Although some hospitals are run by the government, most are run by private organizations. About 70% of hospitals are nonprofit, leaving the rest in for-profit hands. Most physicians, therefore, also work for private organizations and are not employed by the public sector. Other components of the healthcare system are also in the private sector, including pharmaceutical and medical device companies. Research is paid for by both public and private sources, with a little bit more coming from the private side. Added together, however, U.S. spending on medical research accounts for the vast majority of R&D spending in the world. But where countries differ the most is in how they give citizens access to their systems. In this area, the United States is somewhat of an anachronism. Until recently, about 15% of people in the United States were uninsured. This meant that if they needed care, they'd have to pay for it out of their own pocket. And unless you've been living under a rock, you should know that healthcare in the United States is really, really expensive. So that's a problem. It means that a lot of people don't get the care they need, and it means that we're failing a large number of people who live in the United States. About 60% of US citizens get health insurance from their employer. These plans usually don't charge people different amounts based upon factors such as age, gender, or past medical history. They range in benefits, but for the most part, they cover preventive care, care if you get sick, and prescription drugs. Plans vary in terms of how much people have to pay out of pocket for them, but we already did a video on how private insurance works, and you really should have watched that already. About 15% of Americans are covered by Medicare, and most of them are elderly people. Medicare is a national social insurance program run and administered by the federal government. It's the closest thing we have to what most people refer to as a single-payer system, where all people are covered by one type of insurance. But Medicare is pretty complicated. First, there's Medicare Part A, which covers you if you're hospitalized. It's pretty much free to most people over the age of 65, and almost no one doesn't get it. Medicare Part B covers outpatient services and is sometimes deferred by people who are still getting insurance from their jobs. It has a pretty low deductible and then has co-insurance of 20%. It covers tons of stuff, including pretty much all tests or procedures you might get outside the hospital, as well as lots of medical equipment that you might use. There are private supplemental Medigap policies that are offered by private companies that often cover the co-pays or co-insurance, or add in extra benefits. Almost everyone buys one of these too, so that elderly individuals wind up paying much less for their health care than you'd expect. Medicare Part C, or Medicare Advantage, is an opportunity for private companies to offer Medicare-like benefits better than the government can. If they do, and they do it for less money, they get to keep the extra in profit. Medicare beneficiaries can opt into Medicare Advantage plans instead of traditional Medicare. They sometimes have different benefits that appeal to them, and about a quarter of them choose such a plan now. And Medicare Part D contains the prescription drug plans. They're actually designed and run by private insurance companies, but they're approved and paid for by the federal government. Individual Medicare beneficiaries pick the Part D plan they like depending on what drugs they think they might need. That's Medicare. Cost us about $536 billion last year. The other big government program is Medicaid. Unlike Medicare, Medicaid is a state-based program. Basically, it's supposed to provide healthcare coverage for the poorest among us. There are some minimal federal guidelines that are set for Medicaid, and then each state gets to implement it as it sees fit. Some states are more generous and some less so. Generally, Medicaid is meant to cover those at the low end of the socioeconomic spectrum. The government defines poor this way. While you look at that, remember this amazing fact. A single parent with a child who makes minimum wage earns more than the poverty level. That's how low the line is. Regardless, traditional Medicaid must cover kids under 6 years of age to 133% of the poverty line, and kids 6 to 18 to 100% of the poverty line. The State Children's Health Insurance Plan, or SCHIP, ups this to about 300% of the poverty line in most states. Medicaid also covers pregnant women up to 133% of the poverty line, and parents to 1996 welfare levels. Finally, it covers the elderly and those with disabilities who receive supplemental security income. The first important thing to note is that adults without children aren't mentioned at all, and in most states, they can't get Medicaid. Let me say that again. In most states, even the poorest adults without children, even those who make nothing at all, don't get Medicaid. And it gets worse. Those 1996 welfare levels can be super low. So low that, for instance, in Arkansas, a couple with 2 children making $3,820 a year is too rich for Medicaid. Granted, some states are more generous, but in many of them, parents have to be very, very poor in order to get Medicaid. The Medicaid expansion in the Affordable Care Act was supposed to fix this. It was supposed to give Medicaid to everyone who makes less than 138% of the poverty line, regardless of whether or not they have kids. It would have finally made Medicaid the universal program for the poor that many already believe it to be. But because of the Supreme Court decision that made the Medicaid expansion optional, lots of states are refusing it, leaving an additional 5 million people with low incomes with no insurance this year. In 2009, Medicaid covered more than 60 million Americans. About 1 in 3 children are covered by Medicaid, and 1 in 3 births is covered by Medicaid. A lot of Americans are in poverty. In 2011, Medicaid cost us about $414 billion. There's also the Veterans Health Administration, which is totally a government-run system that provides care to veterans, and TRICARE, the military health insurance program that applies to some veterans, military personnel and retirees, and dependents. TRICARE works more like a private insurance. Think that sounds complicated? It is. Interestingly, while about 2/3 or so people get their insurance from private companies, only about 1/3 of spending comes from the private sector. In other words, the government has to cover about 1/3 of people in the United States, but has to pay about 2/3 of the bill. Tell me again how the government isn't getting the short end of the stick. The money involved in healthcare in the United States is simply unbelievable. You may remember this video of John's, which talks about how out of control our spending is. Go watch it again. It's based in part in a series I did on my blog, and the link for that is in the video info section below. I've also added a link to a series on quality in our system, which is, well, not what you'd hope for given all that spending. Obamacare will change some of what I said, but not by much. Basically, we hope to get some people who didn't get insurance through their jobs, Medicaid or community-rated guaranteed issue insurance like employed people get. With respect to the Affordable Care Act, we're only talking about 30 million people or so, or about 10% of our population. And for more info on that, go watch our first episode. So that's the US healthcare system, as neat and packaged as I can make it in under 10 minutes. It's private insurance for most, Medicare and Medicaid for some, and VA or TRICARE for a few. How does this compare to other countries? Keep watching future episodes to find out.
All right, so like a lot of what we're going to do today, that's a whirlwind tour covering a vast sort of set of topics, but at least it gets it out there in terms of the big picture, more or less from the federal perspective, and then of course there's many more layers of healthcare to deal with. So now shifting a bit to some of the issues that have raised concern. and not to focus entirely on the negative, but to actually be looking at ways to change it. The idea among many people is if you're going to change something, first you have to understand it, you have to be able to describe it. And again, in the course of less than a quarter, we've tried to give you at least a sense of that, which is most of what you're going to get in terms of the big picture in terms of your dental school education. There'll be a few sessions in some courses that will talk more again about the healthcare system, but this was an area that was had been in our curriculum in the past at UCLA, got diluted and fragmented a bit over time, and now we're trying to bring it back together in one place. So the next couple of little videos, again, these are short, relatively short, uh, talking about effort that's been made on behalf of the Institute of Medicine, now called the National Academy of Medicine, which is a big nonpartisan group at the federal level that Congress and other policymakers often turn to deal with really more some of the bigger, more complex issues. So we're going to hear a little bit about a report that the Institute of Medicine released called "Crossing the Quality Chasm," which helped to really get it out there in front of people that we do have big problems with the quality of the healthcare system and the structure and financing of the healthcare system. So we're going to first listen to Dr. Don Berwick, who was one of the founders of the Institute for Healthcare Improvement that's done a lot of work in this area.
One of the most important things that happened in that report was that it gave names to the dimensions of quality. If you're buying a car, there are dimensions of quality: safety, fuel efficiency, comfort, fun in driving, durability, and so on. We're used to that. Well, what are the dimensions of goodness in healthcare? And the Institute of Medicine Crossing the Quality Chasm report gave us 6 dimensions and said these should be the areas for healthcare to improve on. It also summarized a lot of the research literature on the current levels of performance for those 6 areas. And here are the 6 areas. The first one is safety, back to the report from a year and a half earlier, To Err is Human. Safety means we're not harming people with our care. We're not adding to the burden of illness. So a safe healthcare system reduces hazards and risks from the care itself, safety. The second dimension they called effectiveness, and that was a term that sort of was meant to mean matching science to care. So if science says that this drug can help in this disease, then we use that drug. And if science says this can't help, we don't use it. So avoiding overuse of things that don't help and assuring use of things that do help, avoiding underuse, that's effectiveness, lining up science with care. There are big problems in effectiveness. The RAND Corporation famously published a study a few years ago which showed that of the needed effective care that Americans should get, when they tracked 7,000 people over 2 years, those people who had all sorts of things ranging from just well care to serious chronic illness, those 7,000 people failed to get 45% of the care that would have helped them. So that's effectiveness. The third dimension is patient-centeredness. And this is a pretty subversive goal. It means people should be in control of their own care. They should make decisions about what affects them. We say, nothing about me without me. It's putting the patient in the center of the care system and giving them power and control over their own lives and their own care. The fourth dimension is timeliness, which means avoiding delays. People are quite familiar with waiting rooms. We wait a long time to get to see the doctor in the emergency room or waiting for an appointment. In all other industries, timeliness is an important dimension of quality. You don't want to wait everywhere. Well, nor do you in healthcare. So timeliness is reduction of needless delay. Some delay is instrumental. You want to wait to see what happens, but there's a lot of non-instrumental, very costly delay. The fifth dimension is efficiency, which means avoiding waste. We throw out so much in healthcare. We give things that can't help. We duplicate procedures and tests. We lose records. We lose the ideas of the workforce by not inviting them to join in invention. So efficiency is a big word. It means stop wasting stuff. We're very, very wasteful in healthcare. The last dimension, which some people think should be the first, is equity. And that means closing the gap in justice in healthcare, basically. Right now, the biggest predictor of your health status in our country remains your race. If you know someone's race, you know much more about their future in health than almost anything else I could tell you about them. A black baby born in inner city Baltimore this year has a life expectancy of a male that's 7 or 8 years less than a white baby. That's a quality dimension too, equity. So safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Those are the names of the dimensions of quality that the Institute of Medicine says we should work on.
Yeah, great. And just a little short, about 2-minute one here to put that in a global perspective as well.
Poor quality healthcare affects far too many people around the world, with staggering economic and human costs. Across the globe, healthcare must be redesigned at the systems level. Leaders should develop strategies and policies guided by transparency, accountability, and continual and substantial improvement to care. Countries must work with their citizens and leverage existing and emerging technologies, shifting towards preventive and anticipatory care to promote better health outcomes for people. Health systems of the future should also enable users to become active participants in their care and decision-making. Care can be delivered at the site of the user, not just at brick-and-mortar health facilities. Progress is being made, but this groundwork must be expanded to realize the full potential of digital health and systems change. The promise of these approaches to improve health can be seen around the world. The time to act is now. To learn more, visit nationalacademies.org/global health quality.
All right, so let's stop and pause just a second, see if anyone has any either thoughts, reflections, questions about the big picture, how at least groups that have been thoughtful and really tried to understand what really goes into providing healthcare and what's valued in healthcare, how that can be at least a framework for looking to improve different aspects of the healthcare system. Any thoughts or questions on that? Keep an eye here, or Leslie can keep an eye on the chat as well. So if you have something that comes up along the way in the videos. All right, so those are big picture sort of ideas, right? Big groups of experts pulled together to really think about issues, to define issues, to sort of lay out an agenda for how you're going to move from where we are now forward toward creating a better healthcare system. So at least that gives us some sort of direction. Let me now move on. So there's just a slide just of mine to show you the Crossing the Quality Chasm report. So all of this information is available online. So, if you're really interested, you can get in there and dig down on some of these, but at least those 6 dimensions or aims for quality improvement have outlined here in a couple of different ways. One with a mnemonic on the right, steep, and one a little bit more in the order that the IOM laid it out on the left. All right, now I'm going to show you two videos here, a little bit longer than the previous ones, and they are a presentation by a physician who, as I said earlier on, started out, practicing, wanting to serve people, wanting to serve the neediest of people in Philadelphia, and having an experience there, but then getting a bit frustrated with the system that he was working in and deciding he was going to do something about it. So we'll start off with this one on the left.
Thank you so much for the chance to be here today. I'm a family doctor, I've spent the last 12 years in the city of Camden. It's one of the poorest cities in the country, first, second, or third poorest city, first, second, or third most dangerous city. 3 of our last 6 mayors have been indicted and convicted of corruption, and we face enormous challenges in the city. For most of that time, I was a frontline provider. I speak Spanish, and this was my office in a Spanish-speaking part of town. 3 exam rooms, running from room to room to room, seeing kids, adults, delivering babies, doing home visits, really trying to deliver old-style care. And what I'm going to talk about today is, I think, the challenge really for the next 100 years as the baby boomers age and our society continues to spend more and more on healthcare, how we both deliver high-touch care as well as high-tech care, how we right-size our delivery system. I'm currently now the full-time executive director of a nonprofit in the city of Camden called the Camden Coalition of Healthcare Providers. I'm not in my office anymore. That office is empty now because the payment rates in New Jersey for Medicaid are some of the lowest in the country and kept falling during my time. I was paid $19 to $35 by the time I went out of business in this office. And you have to run pretty fast from room to room to room to make it work. And I think it's a harbinger of what's to come in healthcare, that we have a marketplace of healthcare in which we pay too much for a certain set of services and not enough for another set of services, and that it's eroding our primary care base. And what happened to me is going to happen all over the country as students vote with their feet and choose not to go into primary care. I want to tell you a brief story of an outreach team that I run that goes out and meets the highest cost, most complex patients in Camden. And our team got a referral from a very good doctor, went out to see the patient, and it was a patient in his 70s who had sugars in the 500s and was going to the hospital and emergency room over and over and over. And he had a great doc, and his doc said, I don't know what's going on. Can you go figure this patient out? So my team, a nurse practitioner, community health worker, and social worker, went out and met with the patient. And the first thing they wanted to do was watch him use his insulin. So he set the bottle of insulin down, he put a syringe into the bottle, and drew up 50 cc's of air and went to inject it into his arm. And my team was horrified. And they slowly began to realize that he was sight impaired and that he couldn't see the syringe and had actually been doing this for many years. He went to the refrigerator and he pulled out 2 bags of insulin that had partly full bottles. And he said, I use my insulin every day, but I can't seem to empty the bottles. And the pharmacies just kept bringing his medicine. And I really think this is a metaphor for what's going on in a healthcare system. Any of you could have fixed this if you had walked into his house and watched him use his insulin. Any of the many nurses in the triage of the emergency rooms, his primary care docs, the front desk receptionist could have fixed this. And it's really a metaphor for what's going on in healthcare, which is, once again, we pay too much for a certain set of services. If you cut, scan, zap, or hospitalize someone, you get paid far more for that hour of time than if you talk to someone. That in healthcare, it doesn't pay to talk. If you wonder why your doctor is running for the door handle after 10 minutes, it's because they're not paid to stay in the room. They're paid to run from room to room to room as fast as they can. That the entire delivery system makes far more money from cutting, scanning, zapping, or hospitalizing you. And that's going to be an enormous challenge as we go forward. The bulk of the long-term federal debt, the dotted line here is 2010 through 2080. The dark blue is Social Security. The top part, Medicare, Medicaid, the Children's Health Insurance Program, is the portion of the federal debt attributable to healthcare. The bulk of the federal debt going forward, the debt ceiling, all the fight going on at the federal level, is my industry. It's healthcare. And it goes up by about 4 to 10% every year, inexorably. It's currently 18% of the economy, or 1 in every $5, and it will go to 25% of the economy, 1 in every $4, and there's almost no way to change that. We have a freight train headed down the tracks with 85 million baby boomers on it, and no idea how to deliver efficient, cost-effective, high-quality service. We spend twice as much as every industrialized country, and we cover not all of our citizens, and by many objective measures, deliver very poor quality service. This is a famous study called the Dartmouth Atlas, which looks at Medicare, which is people over 65, in every state, and says, if it's a scientific discipline, it should be the same from state to state. And it turns out to be highly variable what we spend. So this is doctor and hospital spending in all 50 states. My state, New Jersey, is the most expensive state in the most expensive delivery system in the world, $39,000 per Medicare recipient in the last 2 years of life. Philadelphia turns out to be a hotspot for cost. New York turns out to be a hotspot for cost. And it turns out if you pull the lid off of this, one of the predictors of this turns out to be the supply of services. If you want to know how many people in Philadelphia right now are admitted to the hospital, don't count up the number of sick people. count up the number of hospital beds. If you want to know how many people visited a cardiologist last year in Philadelphia, don't find out how many heart failure patients there are. Just ask how many cardiologists are there. That it's a very unique industry and that it can drive its own demand, that rarely do not follow the directions of the doctor who says, we're going to admit your mom today up into the hospital. To get detailed about this is a famous study that was done on people who have a bad knee. These are 50-year-olds with torn cartilage. And this is a bread and butter procedure. It makes lots and lots of money. And they did what's called a randomized controlled trial. They did a sham arthroscopy. So they put the scope in and just took it back out. And they didn't do the normal trim job. And you woke up with a Band-Aid on your knee and you didn't know which group you were in. It turns out that both groups got better at the exact same rate. That this procedure makes no difference. If you're an athlete and you have an acute tear, it's a miracle. It's an incredible technology. But we misapply this technology. We do 650,000 arthroscopies. The reason you get better is someone takes you out of work for 12 weeks, tells you you don't have to cook or clean, that you go to physical therapy 3 times a week, and you'd all be healthier if I did that for you. Over and over and over in healthcare, we misapply technology. We take a good technology and begin to misapply it. So what happens is everyone wants to do this because you make a lot of money doing it. So they run out of sick people. So then you put lots of billboards up and say, our hospital's better than your hospital, or our doctors are smarter than your doctors. And it still doesn't work. There still aren't enough sick people because everyone's built capacity to do this. So then you work down the continuum to less sick and less sick and less sick people, to the point you're doing stuff that doesn't matter. And we're doing a whole lot of stuff that doesn't matter, to the point that we have inflated a bubble in our country of unnecessary hospital and specialty care. And it's the mother of all bubbles. It's a capacity bubble much larger than the banking bubble and the housing bubble. This is 18% of our economy. The finance industry was 7%, housing industry was 11%. Another famous study showing that angioplasty, putting a stent in someone's heart, doesn't work. They randomized people to talking, to aggressive medication management, or putting a stent in, and they got better at the exact same rate. So if you have a heart attack, a stent is a miracle. But we ran out of heart attack victims, so then we started putting stents in anyone and everyone. So that if you have a 90% blockage, an 80% blockage, a 70%, a 60%, on and on, we misapply technology over and over. I want to bring this down to Camden now and describe how this plays out in Camden. I managed to get raw claims data, billing data for every Camden resident now from 2002 up to 2011. This is very hard to get. This is business intelligence of the hospitals. And quickly learned, we had no idea what we were doing at the time. It still is in Microsoft Access with open source encryption software. We use, it cost about $1,000, $2,000, the whole setup for this analysis. We quickly learned that half the population uses an ER hospital in 1 year, that someone went 324 times to the hospital in a 5-year period. Someone went 113 times in 1 year. In Trenton, someone went 450 times in 1 year. The total revenue or payment to the hospitals in Camden, 9 square mile city, 3 hospitals for just emergency room and hospital care, is $460 million over a 5-year period, plus $200 million in charity care. $650 million to buy disorganized, what I would argue is poor quality care, unnecessary care in many instances. The most expensive patient had $3.5 million in receipts. This is almost all your money. This is, because it's such a poor city, this is almost all publicly funded. 30% of the costs go to 1% of the patients, 80% of the cost to 13% of the patients, and 90% to 20% of the patients. A small sliver of the patients are driving much of the cost. The #1 reason to go to an emergency room in Camden is head colds. 12,000 visits for head colds over 5 years. #2 is ear infection. #3 is viral infection. #4 sore throat, asthma, stomach virus, all primary care problems. Most of these patients have insurance. And the emergency rooms are making $150, $300, $500, $800, $1,000 for these visits. So offices like mine in Camden are closing up and they get boarded up. They sit empty, and the emergency rooms have tripled in size and the hospitals have grown. And that is a metaphor for what's going on all over the country, that hospitals are getting larger, that the healthcare industry's specialty and hospital side and acute care side is getting bigger and bigger because we're paying too much to cut, scan, zap, and hospitalize, and not enough to talk to people. These are cost hotspots. This is a map of the city of Camden mapping out all 3 hospitals' data to find out where do the expensive people live, and do they live close to one another? This is 5 years of data, and the red areas on the city map over here, which are a very small area, are 6% of the city blocks, 10% of the landmass, 18% of the patients, 27% of the visits, and 37% of the receipts. The two most expensive buildings, one's at the base of the Ben Franklin Bridge. 600 patients cost $12 million in receipts just for hospital care over a 5-year period. And the Abigail House had 300 patients with $15 million in payments to the hospitals over 5 years. This is big business. There's a lot of money moving around here. And unfortunately, if there was an outbreak of health and well-being, if the hospitals in America and Philadelphia lost 5% of bed days right now, they would all close. They would go under. That the business model of a hospital and a specialty office is the same as the airline industry and the hotel industry. That it's occupancy rates and turnover, and that's their profit model. You know, this is a model in which it's a volume-based delivery system, and the more clicks through the turnstile that all of you make and your relatives make, the more money you make. You know, essentially good doctors and good hospitals go to work every day, but ultimately deliver a fragmented, disorganized product. And many of you won't know this until you're lying in a bed yourself or your relative's lying in a bed, and you start to realize that you know more about the medical case than any of the doctors walking in the room, because none of them are talking to one another. These are both beautiful buildings. This is not a problem of, you know, crime-ridden, ugly buildings. These have great management. This is a story of disorganized healthcare. I've spent about a year in the top building doing community organizing, asking the residents, do you feel like you got $12 million worth of healthcare in the last 5 years? And the answer is no, they don't feel that way at all. They've seen this data and they're appalled. And we videotaped their stories, and their stories are terrible. I'm deeply, deeply, profoundly embarrassed by how bad their healthcare is. So we've done a lot of community organizing, and we've joined with a church group called Camden Churches Organized for People that's part of a national faith-based community organizing group. And we're doing community organizing in health because we've got to pull aside the curtain and talk about what's really going on. If we want patients to be engaged, they need to know where the money is and where the power is. We pulled together residents from the building and across the city and also from across the country and came together, and I sent them out to all my stakeholders. And I said, go out and ask them, how do they make money? And what are they worried about in the future? And we came back and mapped all that out. So that's mapping all the money in healthcare out up here, and then mapping out the point of view of each stakeholder. Then in the evening, we came together in a church. And my feeling at this point is this is a moral, ethical, and political problem. It's not a technical problem, fixing healthcare. So we came together in a church that's right next to Northgate, because it turns out that a lot of the residents that live in this building go to this church. So it was very convenient. And that's my hospital CEO up on the left. That's a state official, the head of the New Jersey Chamber of Commerce, and the woman in pink lives in Northgate and has sarcoidosis and has terrible stories about how hard it's been to access healthcare. That healthcare is based on the average model. If you're the average patient, you can sort of get healthcare services, but as you get sicker and sicker and you become an outlier in the delivery system, that the whole system begins to fall apart. That if you're blind, deaf, disabled, if you have chronic illnesses, if you're older, if you don't speak English, the delivery system begins to fall apart because it's a volume-based system. And you make a lot more profit margin if you run to room to room to room seeing head colds than if you spend time taking care of sick people. We made a promise that night. We literally hung a covenant on the wall, and we promised one another that we're going to stop pointing fingers, that doctors were going to stop calling patients non-compliant, that patients were going to stop voting with their feet and not going to the doctor and not taking their medicines, that hospital administrators were going to own the fact that this is a volume-based model and needs to change, and that the insurance companies were going to get in the game here and help us fix this. And we made two concrete promises. One was to pass legislation in New Jersey which created a shared savings model. So if we all worked together in the city of Camden and bent the cost curve, that we could capture a portion of the savings. And the second promise was to listen to Northgate residents. And what they told us, and this is the outcome, is they wanted a clinic right in their building, that moving sick people around in the delivery system is a waste of money. We need to bring healthcare to patients. So about 12 weeks ago, this is a ribbon cutting with our state senator and our mayor and all our political officials, and that's Pilar cutting a ribbon in the first floor of Northgate for a very small primary care office. And it's been open for about 12 weeks. It's staffed about 2 to 3 days a week. And this is a great experiment. My feeling is that if I can't bend the cost curve and improve care for one building, I'll never do it at the city level. And because we have all the claims data, we can track the outcomes of this project over time. We put a yoga class in there, a diabetic support group. I'm going to throw everything in the kitchen sink at one building until I figure this out. We've done the same thing around 1 patient, and then 2 patients, and then 5 patients, and then 10, which is go out and meet the most expensive people in the city and build healthcare around the most extreme patients. Because after you've cared for a homeless schizophrenic with a brain tumor and a diabetic foot ulcer, everyone else looks easy. And the other thing we've done is a deep dive into specific primary care offices, because if I can't fix one office and improve primary care, then I can't do this at the city level. This is the outcome for the legislation. We spent about 2 years, and I never thought I would be going from running from room to room in a little primary care office to essentially going out of business, to running around the state trying to figure out what's a business model in healthcare for doing the right thing. And this legislation was signed by a Republican governor, passed with bipartisan support. So if you want to know what a Republican will support in healthcare, it's better care at lower cost with no upfront money. There's no upfront funding with this. But if we bend the cost curve in Camden and improve quality, then we can capture a portion of the savings back through a nonprofit shared intermediary. Our strategies are very concrete. We're going to put nurse practitioner clinics in 5 high-cost buildings, have at least 5 outreach teams seeing the high-cost complex patients. We'll have 15 nurses embedded in 15 primary care offices to catch sick people, pay attention to them, and what's called same-day access or same-day appointments. And that's it. So the bet is on in Camden as to whether we can bend the cost curve. And we signed our first contract with United Healthcare, that is a large Medicaid payer in New Jersey, as of September 1st. So I'll let you know in a year and 4 months if we pull it off. Thank you very much.
All right. So before I go on to the second one, just to a couple of comments. So, he's talking about Camden, and he said, well, one, first, second, or third poorest city, United States, all kinds of issues, and it's easy to sort of think, oh, okay, so, well, that's just some little subset of places that are, where it's really unfortunate, and that's really not sort of mainstream America, and that's not mainstream America healthcare. But it is, as he said, that's really a metaphor, and it may be a bit of a worst case scenario because of a lot of social determinants, but it's not that just it's some little small number of places. So, I can tell you, my wife recently went to the pharmacy to get a maintenance prescription for something that she's taken for a long time. Um, there's a mess up between the physician's office and the pharmacy, and the prescription gets written for half the number uh, of uh, of pills that she needs. So at least 3 phone calls later, and it's still unresolved. Uh, there have been 2 efforts on the part of something called the UCLA healthcare system to fix that little situation, and it's still unresolved as of this morning. So, imagine if you're talking about, she's fortunate enough, she still has a few days supply because she knows enough to start early to do this because of the unreliability of the healthcare system we have. And imagine if you're talking about people who have many, much more serious types of conditions, like the guy with the diabetes and whose now diabetes has probably affected his eyesight, and now he can't take his medication. So, and if you think about a model of care that is set up on the volume to volume to volume, the run from this room to that room to that room, that is dentistry to a huge degree in this country. Um, and as he said, there's a lot of well intentioned people working within well intentioned organizations that are looking to actually make that work and to do good when they go to work every day. But the issue and what you learn when you really study quality improvement, that most of the problems, if you will, are a result of a system and the way the system is designed, and obviously the way the system is financed and the incentives that are set up for individuals to behave. And they may be behaving in a somewhat rational manner within that system, but the entire system is really not accomplishing what it needs to accomplish. Any comments, reactions about that?
I have a comment.
Sure.
Well, maybe a question. I guess with seeing that we need so much structural changes and the financing is coming from private companies, how are we supposed to make these changes when these private companies have so much money and
Well,
can
okay.
spend it on lobbying and
Yeah,
all
yeah.
these other?
Sure. Yeah, sure they can, right? Yeah, well, okay. So the first answer is it won't be easy, will it? If it's easy, it would have been done by now. But uh, let me just recalibrate just a little bit. If you remember what he said in the first video, most of the money in this system is coming uh, from public expenditures. Okay, so we're paying for this, uh, and that doesn't necessarily make it any easier to affect the change because, as you said, once you start to really encapsulate and create these programs, and then in some people's eyes, start to feed the beast, um, then uh, then obviously there's vested interest. And when you're talking close to 20% of the entire gross domestic product of the country, you're talking about way more than the defense industry. You're talking about 3 times than what we spend on education, primary care education. We're talking big dollars and big bucks, attract special interest, right? So it's not going to be simple. It's not going to be easy. And one of the things that I've tried to do with the course is at least show you some other countries, but I can tell you every one of those other countries you have is facing the same set of challenges that we looked at, those developed countries. Um, and so, it's a great question. How do you actually break through this? Well, I think, Dr. Brenner's answer to that is, first of all, I got to figure out really what the problem is, right? I got to quit just kind of complaining about my US healthcare system. And I got to understand down at a granular level. And that's where individual people can actually, make a difference. Because what he said, if you listen to him, he said, I'm not going to go talk to the city of Philadelphia about a solution to this. I'm not going to go talk to United Healthcare about the solution for this until I know, until I get 5 practices and some number of people that I really understand, both what the issue is and some of the things that can be done to make this better. You'll hear in some of the later presentation here, and I don't want to start giving any of the presentations. This is not going to be a fix, and you heard in the first video. And a lot was made in an ongoing battle still about something called Obamacare, but Obamacare didn't fix the whole system, right? It started off with grand aspirations, as other major efforts have before to reform the system. But it ended up being more about reforming payment and insurance and coverage and not the system overall. So it's not going to be easy, but it is going to come. And I have no crystal ball to where I can say that this is going to happen in dentistry or what's going to happen in dentistry. But, we're talking about a model, though, that again, probably worked for your grandparents, probably might have worked reasonably well for your parents, but it's going to change. And that's all we can say, right? So I'm just trying to give you a little bit of a perspective here and keep it positive enough. This is not doom and gloom, but just know that you need to keep that mind open. And you're in your first year of dental school, so please keep that mind open. You're going to hear a lot of things over the course of the next 4 years about what dentistry is and isn't. But you'll make the decisions, and you've got the career ahead of you, and you have the ability, just like this person, Dr. Brenner, to say, look, I might not be able to fix the whole thing, but at least I can do better for people that I care about. And so thank you for the question. I'm going to go to the second one now. This one's a little bit shorter, and he's going to touch on some of the same themes, but I thought there's enough, again, additional information in here that it merited putting 2 in.
Great, thank you. It's really a pleasure to come and talk with all of you today. So I work over in Camden, New Jersey, which is a small, sad, poor city not far from here. It's right across the water in New Jersey. It's 9 square miles, 79,000 people, and the first, second, or third poorest city in the country. I spent much of my career there working in a tiny little office, which has 3 exam rooms, and I saw kids, adults, and I delivered babies. And I was very happy there. I enjoyed what I did, but I really felt like I was falling short, that the patients that I was most interested in were the sickest and the most complex patients, but that I was falling short and the healthcare system was falling short. We have an incredible healthcare system in which we routinely pull people back from the brink of death. We transplant hearts and lungs, and we should be proud of our ability to do all those things, but we don't organize people's care very well. They get overwhelmed in our healthcare system. Regardless of whether you're poor, you're middle class, or you're upper class, some of you or some of your families will have the experience of being lost and terrified in the healthcare system. So that was the problem I was seeing every day with my patients. At the same time I was seeing patients, I was having a hard time keeping my office open, that my office was beginning to go under financially. And part of that was because I was so interested in the sickest and most complex patients, but also because my payment rates kept falling. So I started out getting maybe $40 to $50, $60 a patient. By the time I closed, I was getting $19 to $35 a patient. So this is my office today. It's boarded up and closed in the city of Camden. And if zealots like me can't keep offices like this open, then that really calls into question how we construct our healthcare system. So this led me to really begin asking questions about where the money goes in healthcare. And if I couldn't pay my bills, where is the money going? Because at the same time that my office was going under, we were building new wings on hospitals in Camden. We were tripling the size of the emergency room. We were buying Gamma knives, buying CAT scanners, hiring specialists. So there clearly was money in healthcare. And in fact, it's almost 20% of our economy, healthcare. We spend twice as much in America as every other industrialized country. So I knew there was money in the system. There just wasn't money in my office to be able to keep my office open. That led me over the course of time to begin to collect data from the 3 local hospitals in Camden and put it into a database and start to figure out where is the money in healthcare. So we managed to get the name, address, date of birth, date of admission, charges, receipts, and insurance status for every Camden resident from Cooper, Lourdes, and Virtua. And people don't leave the city, so this is a very good data set to be able to understand where's the money. And let me show you what I learned. We learned that half the population of Camden goes to an emergency room or hospital in a single year, that this is mostly your money. This is the taxpayers' money. Because the city is so poor, this is mostly publicly funded service. So someone went 324 times in 5 years. A single person went 113 times in 1 year. As we've learned around the country, there are people who've gone extraordinary numbers of times to hospitals. Up in the city of Trenton, someone went 450 times in a single year. You all, through your taxes, paid $108 million a year for a city of 79,000 people to go over and over to the local emergency rooms and hospitals. It's been a great economic revitalization plan for the city of Camden, so I want to thank all of you for the money you've spent. The most expensive patient was $3.5 million, single patient. 30% of the costs go to 1% of the patients, 80% to 13% of the patients, and 90% of the costs to 20% of the patients. It turns out that that basic rule is true everywhere. Even if you look at middle-class people, if you look at an employee group, everywhere you look, a small sliver of people are actually driving much of the cost in healthcare. And the question you all should ask is, are you getting your money's worth? If you are a patient, did you get your money's worth? And as a society, are we getting our money's worth? And it turns out that we're failing because we ignore outliers. And outliers are people who are way out on a long curve of data, who have complex medical issues, who we simply ignore. The average physician in America has about 2,500 patients as a primary care provider, and each week, probably only 5 people are admitted and discharged from the hospital that are part of their practice. But we ignore those patients. We run from room to room to room treating head colds instead of focusing on the 5 people who were terrified, sitting at home, confused, overwhelmed, had all their meds changed, and are calling, sitting on the phone line, trying to get through the office and get appointments. Then we run into the room and run out in 15 minutes, because that's how we've constructed the American healthcare system. It doesn't have to be that way. The number one reason to go to an emergency room in Camden, New Jersey is head colds. There were 12,000 visits for head colds over a 5-year period. Number 2 is ear infection. Number 3 is viral infection. Number 4 is sore throat. Number 5 is asthma. Most of those people have insurance cards. Those are mostly poor moms and kids. And the emergency rooms are actually making a fair amount of money on this. That's why the emergency rooms are growing larger in America. This is profitable. Most emergency room utilization is not driven by uninsured people. I want to share a very specific example of the kind of things that we see. This is a 52-year-old woman. She's Spanish speaking, and she was admitted for inability to breathe. She lives with her family in Camden. This is a real patient. In 6 months, she got readmitted to the local hospital 6 times. She lives on a ventilator. She has a hole in her neck, and she has severe lung disease. During the time that we worked with her, each of these red lines is a trip to the hospital. On the left side of the graph is all the time that my teams worked with her. In 1 year, she had $745,000 in bills sent by the hospitals and $95,000 in payment from you, the taxpayers, for her care. Just for the hospital portion of the care. This is time along the bottom. She was in the hospital for 6 days, then 4 days, then 7 days, then she was back for 10 days, out for a couple of days, back for 11 days, over and over and over. So one of the things that I do now that my office is boarded up and closed is I run a nonprofit in the city to figure out how to care for these people better, using a mix of data, coalition building, engagement, policy change, and also outreach teams that go out and find these patients and work with them. And what we found over and over are people just like this patient, Lillian, who don't want to be in the hospital. They're overwhelmed and terrified. We're spending lots and lots of money, but we're really ignoring them. So living on a ventilator is not an easy thing to do. Her family was terrified of the ventilator. And through getting lots of training about how to manage the ventilator and getting the pulmonologist and the primary care doc to play nice and work together as a team, we were able to keep her out. And these repeatedly, all over the country, are the kinds of stories that we've begun to find. So we have the best healthcare system in America until you get really, really sick, and then you get lost in that healthcare system. So why is saving money so hard, and why is this work so difficult? It's a blockbuster video moment for the healthcare industry. This is an existential crisis to the healthcare industry. Because if every American who was really sick, every one of your family members who was really sick, got great care, we would probably cut in half the number of hospital beds that we have. So the revitalization of Philadelphia has largely been based on universities and hospitals. We don't need 4 academic health centers in Philadelphia. When you pay your tax bill to Philadelphia, when you have your contribution taken out of your check for your benefits, we have really expensive healthcare in Philadelphia because we have too much of the wrong kind of healthcare. We have too many hospitals and not enough community-based services. So these same things are impacting healthcare all over the country. And if we did the right thing, if we woke up in the morning, if we saved money in healthcare and delivered your mom, your grandparents, your aunts and uncles great care, we would cause a financial crisis in Philadelphia. We would cause a financial crisis around the country. Almost 20% of our economy is healthcare. That's a lot of jobs tied to that. So, there had to have been a moment at Blockbuster Video when a young executive came to the leadership team and said, you won't believe it. People are renting videos online and they're waiting for the videos to come in the mail. And the leadership team said, no. We've been doing this for years. We have these stores. People come to the store. They look at the videos. They argue with their spouse. They can't agree, and they walk out with a whole stack of videos, and then they return them late, and we charge them extra. It's a great business model. We're going to just keep doing this. And they've collapsed, and it's a penny stock. They're bankrupt, and they're closed up all over the country. This is where the American healthcare system is headed. If we don't make deep and fundamental shifts in how we deliver care, we have this freight train filled with 85 million baby boomers, the largest demographic bubble in the world that anyone's ever seen. 10,000 people turn 65 every day. We can't afford to deliver the disorganized care that we currently deliver to all of those people. The other reason that this is so hard is that we actually don't have a good conception of why people go to the hospital and what leads them to get sick. And one of the most profound findings in our work and in the work of people around the country is work that someone else had discovered that we had to rediscover. This is from a paper 15 years ago that no one in the medical world knows about. And it was a very simple study where a physician in California at a huge healthcare system was an obesity researcher. And he began to realize that when he worked with patients, he could get them to lose weight, but that women in particular would lose a whole lot of weight and then gain it back, and he couldn't figure out why. And he started to realize that the women that were gaining the weight back had had sexual abuse, and that as they began to lose weight, they got unwanted attention and gained the weight back. That led him to create a survey called the Adverse Childhood Experience Survey, which are a set of 10 questions that ask you about the horrible things that happen to kids from 0 to 5. About death of a parent, physical abuse, sexual abuse, one parent hitting another, a whole variety of things. And he sent it out, he had the audacity to send it out to 17,000 middle-class people. And 70% of them returned the survey. Can you imagine returning a survey like that? And they agreed to have it connected to their medical records at Kaiser Permanente, a huge medical record system. And to this day, the number of categories of adverse events is the best predictor we found for medical spending, for medical utilization, healthcare utilization, for obesity rates, for substance abuse, for smoking, for alcohol, for out-of-wedlock teen birth, for poorly controlled chronic illness, for IV drug use, for a whole variety of things. So that's really causing a shift in certain circles, but that idea has not permeated the healthcare. You know, hospitals in America are essentially filled with very damaged people who had horrible things happen to them in childhood. That's not true for everyone, but the folks that are going back over and over and over. Certainly the patients that we're caring for and all over the country that similar programs are finding have similar challenges in their history. This fact is utterly not known in the medical community, and they want to go running out of the room when I talk about it. So we have a long way to go. So I want to close by describing, the essence of our work is this idea of hotspotting. And it was really an idea taken from Bratton's work in the New York City Police Department. And Bratton realized that you had this expensive resource, the police department, and that a small number of people in the community were committing most of the crimes and were actually the victims of a lot of the crimes. And that the police department was not using themselves strategically as a resource. So he began to use data, mapping, real-time flows of data, and then he restructured the entire management of the police department to respond day by day, week by week to the needs of outliers. In a typical classroom in a school, a couple of kids have differential learning styles and don't fit into that school or that classroom. There'll be a couple of families that are down in the principal's office because those families have differential needs. Within healthcare, we've got a group of people who have unique, special, and different needs, and we're ignoring them. And we have to borrow lessons that have come out of other fields to better target our resources and to make sure that we're doing great care for everyone every day. So thank you very much for the chance to talk with you.
Okay, so again, some of a little bit of the same sort of material and the approach that he's taking, but the things I want to talk about is both the use of data and really sort of understanding what underlies drivers of health and take a fresh look about how we can actually use some of the great resources we have within the healthcare system here in a different way to actually really improve health. I'm going to move on to an approach that's been highlighted to do that. And the IHI is the Institute for Healthcare Improvement. It's a group that is headquartered in the Boston area, Boston, Cambridge, um, headed up by Dr. Berwick, who's now emeritus from IHI, but I had the good fortune to actually take a class from him back when he was a pediatrician wandering the streets around Harvard Medical School and Harvard School of Public Health. And he put together this whole organization that's done some really remarkable things, both in the US and internationally. And he's going to tell you a story very quickly because most of these videos now are considerably shorter, 3, 4, 5 minutes at most, that I'm going to show you on these different perspectives. But this triple aim, you'll hear the story, but the three elements of the triple aim are improving population health, not just healthcare, improving and providing better care, and then lowering per capita costs, and doing that all at the same time. So you'll hear a little bit about that on the next couple of videos.
The triple aim was the brainchild of two of our faculty, John Whittington and Tom Nolan, who came up with it in about 2006. I remember them coming in with the idea. And it was a real breakthrough. So the goal they had in mind was to articulate in a very efficient way the aims of healthcare. Up until that time, the answer would have been probably the best answer would have been reference to the Institute of Medicine report, Crossing the Quality Chasm, which had laid out 6 dimensions of quality, 6 dimensions of need. They call them aims for improvement. And those, most people in the field now know them. They're safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Everyone up until that point would have said, well, that's what the social need is, the 6 aims. And Whittington and Nolan said, no, wait a minute. That's about if you need the care. So if you need the care, absolutely, those properties should be there when you care for your heart attack, your broken arm, your depression, or you get your checkup. In the individual experience of care. But they said there's actually a second component of AIM, and they call that the health of the population. Because why do you have your heart attack? Why did you break your arm? Why are you depressed? And the causes, they don't lie in healthcare. The cause of illness isn't the absence of healthcare. Healthcare is a repair shop. So they said that society also needs us to help you stay healthy. And the third aim they added, which I think was particularly brilliant, is while reducing per capita cost. And that is because the needs of the society, the people we serve, go beyond healthcare. They've got other things to do with their resources. They may want to go to the movies tonight, or a corporation maybe want to be more competitive and pay its workers more, and government may need to put money into roads or schools. So they posited this collection, this system of aims: better care for individuals, better health for populations, and lower per capita cost as is a complete statement as they possibly could of the social need we're here to fill. It's like a compass direction that tells us what success is. And that became known as the triple aim.
All right. So before we go to the second aspect of triple aim, which also starts to address social determinants of health, there's a phrase in what he said that he just sort of slipped in, but I think is important to think about, right? And that is that the causes of ill health are not necessarily just the absence of healthcare. And he used the phrase that the healthcare system is the repair shop, and that notion has been discussed and is the basis for some of the change, things that are driving change as well, right? Because many people say we don't have a healthcare system, we have a disease care system, and the whole idea is that we're waiting until people get sick, and then we throw all these resources and things at them, oftentimes in a very disorganized way, but it's not truly a healthcare system. So look a little bit now at AAA and intersecting with social determinants.
Let's imagine a patient. Let's call her Mrs. M. She's 46 years old. She's got 2 kids. She's got a mother. Her mother's a little frail. We're trying to take care of her. She has type 2 diabetes. It's not really well controlled. She's got some mild heart failure as well due to some issues that happened when she was a kid. She's holding down a job. She's got a high deductible health plan with her employer. She's trying to make ends meet. She's dignified and takes her responsibilities very seriously. She makes sure that her kids get to school, are fed, are doing well, and taking care of her mother, who relies more and more every day on her. So let's take Mrs. M. What does the AAA mean for her? Well, we know that in Mrs. M's story, for instance, when she gets admitted to the hospital because she has, which is common for patients like diabetes across the country, a hypoglycemic event, low blood sugar. More often than not, we're just beginning to understand in healthcare that the root cause of stories like Mrs. M, diabetics are getting hospitalized, especially at the end of each month across the country at a much higher rate. They're being hospitalized because of food insecurity. In other words, she's at the end of the month before she got hospitalized, she was taking care of her mom. She fed her mom and fed her kids. She paid the rent. She paid for all the utilities. And then she skipped her own meal because there wasn't enough food left over after taking care of everybody else. And yet she still took her blood sugar lowering medications, right? She was adherent to her care plan that we had come up with together. She took her blood sugar lowering medications, didn't have food, and ended up getting hospitalized. This is not a unique story, right? Patients like her get admitted at a rate almost 30% higher than other food secure diabetics. So if we can't address her food insecurity, she's not going to be happy with her care. And I've taken care of patients who are consistently frustrated with the fact that their healthcare system, their healthcare providers are not asking about some of the basic stuff that they know is happening in their lives. I have mold in my home. That's why I have my headache, or I have a problem actually making ends meet right now, and that's why I can't afford to take that medication. Why are you making me have to tell you this? Right? There's anger for a lot of patients. Patient experience connected to the social determinants of health. You think about total cost of care or even per capita costs. When that patient gets hospitalized, Mrs. M gets hospitalized right now, we have an avoidable ED visit and avoidable hospitalization right now. That's dollar signs, and that's per capita costs going up. If we don't address food insecurity, that will continue to happen. Social determinants of health connected to per capita costs. We think about the outcomes of patients like Mrs. M, of a community of folks who live in and around her community, as well as people who have that condition, diabetes. Well, there's no way we can improve outcomes for whole populations of patients in defined communities or with certain conditions like diabetes unless we address food insecurity or other social determinants. So we think about the triple aim, patient experience, the improving outcomes for populations, and lowering per capita costs, if not total cost of care. And every experience I've had, just like the story of Mrs. M, reinforces for me that we can't achieve the full potential of the triple aim unless we recognize that social determinants of health and integrating social determinants of health into our systems with partners in the community is related to each element of them. It is not extracurricular. It is not an afterthought. Every experience that we have in health and healthcare demonstrates that a necessary component of achieving the triple aim requires us to address social determinants of health.
Yeah, so we tried in the class here to at least introduce to you this notion about a chronic care model and the conditions that really are challenging the healthcare system now, and this whole notion that you heard espoused there that we need to recognize social determinants of health. We also, while we're working to improve care that's provided within that healthcare system, you heard the word partner in that last video about partnering with organizations or people in the community who have a way to help us get what's called upstream in the process, right? Any comments, reflections, questions about this kind of movement? Because in a minute we're going to take a look at about what an upstreamist actually is. All right, a couple of additional, and again, these are short little videos that give you an essence of what we're talking about in practical terms.
There are three friends who come to a river, and it's a beautiful day, but that scene is pierced by the cries of people in the water, in the river, crying out for help, in need of rescue. The three friends do what all of us do, especially those of us in healthcare. They jump right in to save those people, adults, children, the elderly. At first, the first friend, the strongest swimmer, says, I'm going to focus on those who are about to drown, just at the edge of the waterfall. Everybody applauds that decision. Of course, it makes total sense to rescue those about to drown, and everybody doubles up and says, let's rescue. People along the sides of the riverbank say that let's invest more resources, give that rescuer what he or she needs. But over time, it becomes clear that that's insufficient. People slip through the grasp of the rescuer. Clearly, something else is required. The second friend actually along there says, you know what, to make this easier, to make our success rate go up, let's coordinate the branches along the banks of the river here and create a raft so we can usher more people to safety, prevent people from going further downstream in need of rescue. We all applaud that. Um, the success rate goes up. Fewer people in need of downstream rescue. More people on the raft getting ushered to the riverbank. And yet, in the course of that work, the first friend and the second friend, the downstream rescuer, the raft builder, realize something is happening that they can't fully articulate, but they see it every day. The people keep coming. The success rate, while better, still isn't as good as they would want. People slip through. They start getting tired. They start getting a little jaded, perhaps. They start saying things like, to the people in the water, "Why don't you know how to swim?" They start considering other rivers to jump out into, leaving maybe the purpose of rescuing. They start getting tired. But like a lot of us, they remain doubly committed to the work, and they remain heroically, nobly committed to rescuing, despite this strange phenomenon. Finally, they realize that they came with a third friend, and they don't see that third friend. They finally spot her. She's in the water. She's rescuing people as she's going, but she's swimming away from them, much further upstream. And they shout to her, "Where are you going? There are people here to save." They're in dismay. They're wondering why their third friend, a vital part of their team, is now leaving them. Turns out she's not leaving them. She's actually in the water again, helping people as she's going. And she shouts back to them, "I'm going to find out who or what is throwing these people in the water." The reason I tell the story that way is because in the American healthcare workforce, and I think in the healthcare workforce in many parts of the country, of the world, we know that we have that first friend. We have that downstream rescuer, the trauma surgeon, the ICU nurse, the intensive case manager, the ER doctors, the oncologists. These are people that are vital, necessary parts of the workforce that we know we need. You want them when you're in dire straits. We're now in the phase of that second friend, the comprehensivist, the raft builder, the person who creates that primary care patient-centered medical home to usher more people to safety, to screen for certain issues, manage chronic diseases, make sure that those who are at risk of disease actually are prevented from becoming sicker. But we know increasingly now that while that's an important phenomenon right now in healthcare transformation in the US, the idea of the downstream rescuer and the raft builder, primary care comprehensivist, while we're in that phase, we know simply by looking at our patients and simply looking at what healthcare looks like on the ground every day, that model of the healthcare workforce is necessary but insufficient. What we have in the healthcare workforce right now, not nearly enough of, but what we do have certainly are that third friend. We have the upstreamist. The upstreamist's job is not to be the hero nurse or hero doctor or hero community health worker who is individually taking on rescuing people, but is instead, as many upstreamists before us have done, thinking about how to systematically understand and address the social determinants of health, where people live, where they work, and bring that understanding into the workforce and the workflows of clinical medicine, of healthcare.
All right. So again, just try to plant the seed as you learn more and more about dentistry and dental care and how it's provided currently, at least in the country. The whole notion about are we still working at that second phase to build more comprehensive primary care people? So to teach a broader gamut of care that goes all the way from diagnosis and something that we call prevention up into more tertiary types of treatment, implants, and all the kinds of things that technology can bring to us now. But also recognizing that um, uh, the path to better health for the population is to get fewer people into the street and to work and focus on social determinants of health. And here's one short little example. I'll give you a little warning. The individual who's the speaker here has got a pretty strong Scottish accent. So train your ear very quickly to listen to what he's saying. He's actually talking about stillbirth, but the example I think is useful.
The stillbirth rate in Scotland is higher than it should be. It's about double the Scandinavian average, for example. Stillbirth is a complex challenge. It's not just get the obstetricians to do something better. It is a real multidisciplinary problem, including families, carers, mums, and sometimes in very, very vulnerable situations. So it could be incarcerated mums, or it could be mums in damp houses that need the housing corrected rather than the obstetrics fixed. So we've brought together social workers, teachers, housing officers, prison officers, criminal justice people, and we've tried to, with the family in the centre of that conversation, tried to find whatever the solutions are. So we've done really practical things like taught mums about fetal movement. So the biggest single thing you can do is train mums to know what to do when they don't feel the baby move for a period of time. Other practical things like smoking cessation in pregnant women, teaching young people how that works and how they can help that. We now do multidisciplinary reviews every time there's a stillbirth. So we talk about it. We talk about it with mum, we talk about it with the social workers, with the obstetricians, the midwives. So we learn both for that family, but also for other families. The rate has reduced pretty dramatically. 18% in 3 years is globally unprecedented. But the 18% is partly because we weren't very good. We were still not at the Scandinavian average. So there is still much to do. This is a long-term challenge, and we're not going to take our foot off the gas to try and fix it.
Yeah, so a brief little example there, and again, how people are using data to understand populations, data from other systems that where they're getting actually better results, better performance across those different aspects of quality and also health of the population. A little underlying story, that individual, Jason Leach, from Scotland, had the pleasure to have lunch with him a few years back at an international meeting. He's actually an oral surgeon, so he began his career within dentistry, but he's now in charge of improving quality of all kinds of care, not just dental or oral health care, but all types of care for the country of Scotland. So you never know where the path is going to take you. Okay. See, so that's social determinants of health and upstream, and of course here's a breakout of all those different types of social determinants that we talked about, or at least touched on, at least in the course, and social determinants really kind of get an appreciation of why they matter and what they are, and recognition, of course, that we have even evidence within oral health care that in fact the more of those factors that are impending upon daily lives of people, greater the likelihood it is that they're going to have poor oral health for a whole variety of reasons. Okay, just about 4 videos to go to wrap up here, so I'll go ahead and get started. Oops, sorry. This one actually is a bit of, this is from an inside. So this is about something day to day, and really about why healthcare providers can't fix the system, at least alone. I mean, obviously, healthcare providers have to be an important part of the efforts that are being made to improve healthcare systems and health, but they can't do it alone. So let's listen to this perspective.
A while back, I was driving to work one day, and my son Adam asked me a question. "Mommy, what do you do for a living? What's your job?" I quickly answered, "Adam, I'm an ear, nose, and throat doctor. I operate near people's brains." I peeked into the rearview mirror. He looked confused. I quickly added, "I help patients to get more healthy." He broke out into a big smile. Later that day, I went to clinic and I started seeing patients, and I forgot about this conversation. And at the end of a busy day, when I was an hour behind, I looked at the clock and it was 4:30, and I walked in with my last patient, Charlie. As soon as I walked in, I asked Charlie, "Hi, sir, how are you doing?" Charlie bristled. "Do not call me sir. You're the 7th doctor that I'm seeing. I've had oodles of tests, multiple blood work. Nobody knows what's wrong with me. And I tell you, there is something that's going on." Puzzled, I examined Charlie. I looked inside his sinuses and I tried to figure out what was happening. But nothing. I couldn't find anything. So I did what all of us sinus surgeons do when we don't know the answer. I ordered a CAT scan. And then I looked at Charlie and said, "While I'm excited to figure out this journey with you and figure out what's happening, I have to go. I'll call you tomorrow with the results of this CAT scan." And off I went to the hospital to see patients and then back to pick up Adam. When I got Adam, he asked, "Did you help patients today?" I smiled and thought of Charlie. Yes, I did. So the next day I went to clinic and I immediately opened Charlie's CAT scan and tried to look through the images to find out what was wrong. Negative. Nothing on the results. Nothing on the sinus scan. Essentially, I was still curious. Puzzled, I scrolled the images myself. I looked through the brain images and the neck images, and suddenly I noted with growing horror that Charlie had a mass that was growing in his brain and eroding through the bone. I called him in, and I let him and his wife see the scan. His wife started slowly weeping, but Charlie looked relieved. "Thank you, Doc, for believing in me." And long story short, Charlie went on to get treatment and still is doing well today, cherishing his beautiful family. But this is not a story about me as a doctor or Charlie as a patient. This is a story about the 1,000 Charlies in the world who are unable to get a healthcare diagnosis. Why is that? Why is it that we have so many talented physicians dedicated to helping patients who are unable to help the Charlies of the world? We all have heard of medical errors. 98,000 people per year dying for preventable errors. But let me ask you guys a question. How many of you have gone in to see the doctor and the doctor doesn't know what's wrong with you? And how many of you have a family member who you know has felt scared because they don't know the answer? And so I'm here to ask you today that we can't solve the healthcare system because maybe we haven't been asking the right questions. Einstein once said, "We can't solve problems by the same level of thinking that created them." And I'm here to tell you today that we need to adopt a systems thinking mindset in order to approach our healthcare crisis. And in order to do that, I pose 3 questions for you today. Now, systems thinking is not a new philosophy. It has reframed conversations in several industries. But the reason it's important is it helps us understand how things are related, events, people, and places, even if they don't seem connected. And what it also does is it looks for leverage points, small actions that have really big impact. So I'm going to ask you 3 questions that I think will help us to find some of that impact. The first is, how do we talk to our doctor as our friend? The second is, why is it that competition is so bad in healthcare? And the third is, why do we fear failure? And what can we learn from it? So let's go to the first question. In order to answer the first question, I want you all to think about this number. As a patient, when you walk in to see your doctor, there's a 15% chance that they're either going to miss your diagnosis or have the wrong diagnosis by the end of the visit. And that's going to increase your chance of getting sicker or dying twice as likely. So where do we go from here? Well, I think that systems thinking asks us to structure the conversation completely differently, to take a step back and really ask, why is this happening? Perhaps because when Charlie went to the doctor, he stated his problem, then he received some tests, got a medication that didn't help him, and was sent home. And the pattern repeated itself. We're trying to engineer a relationship between the doctor and the patient that is efficient but not meaningful. Perhaps what we need to do is change the nature of the conversation and ask physicians that you are able to have the time to step back and listen to Charlie's story. And in order to do that, we have to ask ourselves the following question. Shouldn't seeing your doctor not be something that's rushed? In fact, I believe that seeing your doctor should be like getting together with a friend for a cup of coffee. But I know some of you are still thinking about this 15%. What if we don't know the answer as the doctor? What if we can't find out what's wrong with you? Where do we go from here? And this is where the healthcare system and its competitive nature does not help us. So from the moment we get into medical school, it's a deep culture of competition. We have to get the best grades to get into the specialties we want, be the best surgeon with the fewest complications, and work in the best hospitals. And I found that despite my training as a surgeon, despite doing research, despite teaching at Harvard Medical School, all this enabled me to do is to continue to focus on the body parts that I operated on and not really have a holistic view. And the bigger problem with that was that I was so focused on proving individual performance, for which we as doctors are measured, rewarded, and now publicly displayed, that I didn't have the time to really collaborate with other doctors when patients were trying to get a diagnosis.
Okay, I'm going to pause that one for a second, just in the interest of time here, because I wanted to get to the dental examples. But before I leave this one, I want to actually look at this big question with a little bit of an international perspective on the question of, is healthcare a right or a luxury?
I'm here today to ask you all to ask yourselves, is healthcare a right or a luxury? It's a vitally important question, but before you respond, allow me to challenge you a little. I'll start with a story.
Oh, sorry. We'll go again, and we're speeding it up a little. So, I'm sorry. Haste makes waste. There we go.
I'm here today to ask you all to ask yourselves, is healthcare a right or a luxury? It's a vitally important question, but before you respond, allow me to challenge you a little. I'll start with a story. In 2015, I was offered an opportunity to spend a year training in one of the world's best cancer hospitals in the US. This was a huge privilege for me, and I was really excited to go. The only strange thing was, when I was filling out my starting paperwork for the job, I was being asked questions like, did my 2 young kids have any pre-existing illnesses? I was also informed that even if they were completely medically well, I still had to pay about $25,000 a year in health insurance, or I wouldn't be permitted to work there. $25,000. Now, myself being the product of a more socialized public system here in Australia and New Zealand, this was a foreign concept to me. It was a little scary, in fact, the idea that children may not get medically treated if they didn't have the right health insurance organized by their parents. What if they didn't have parents? What if their parents were on the minimum wage? It felt wrong. It felt unfair. And this was in one of the wealthiest democratic nations on the planet. But anyway, I did the needful, got the insurance, flew to the US, and I started work. And this place was absolutely incredible. Cutting-edge medical and surgical services being delivered by some of the most brilliant and most dedicated doctors and nurses in their field. But there was a catch, and it was always looming in the background. The best way to describe it is that this probably truly was the world's best cancer hospital, if you could afford it. And I struggled with this idea. On the one hand, I had seemingly unlimited resources with which to treat patients, which was actually frickin' awesome. I loved it. But it was a bit like a guilty pleasure because I knew that for every patient I treated, another would get rejected because they didn't have insurance or the right level of cover. So one day, I was sitting in the tea room between operations and I finally blurted out to a colleague of mine, I said, how can you live with yourself as a doctor, knowing that a large segment of your population can't access the care that you provide? Her answer surprised me. She said, the problem you have, Tarek, is you can only really see things from a British colony socialist perspective. She said, you regard healthcare as a birthright and feel that you're automatically entitled to it. But have you ever considered that it may not be a birthright? That in large parts of the world, including here in the US, it's a very expensive luxury. She then went on to say, what makes you think that by being born a citizen of a given nation, that you're automatically entitled to a brand new, big state-of-the-art hospital, the latest medical technology, and the most expensive drugs money can buy, funded by your government and taxes? Don't you see? If that's what you want, then you have to accept rationing and death panels, because there's just no way that any government can pay for high-quality healthcare for all of its citizens. It's simply too expensive. So you have a choice. Crappy, mediocre healthcare for everyone, with long waiting lists, or high-quality healthcare on tap for those that can afford it. I can't lie, I was taken aback a bit by this. I'd never heard it sort of that clearly stated before. But being as stubborn as I am, I decided I'd dig a little deeper. I started researching different healthcare systems around the world. Surely there must be a way to pay for high-quality healthcare for everyone. And that's when I realized she was right, at least partially. You see, in the developed Western world, no matter which country you live in or what kind of healthcare system you have, we are rapidly heading towards the day when our healthcare will be completely and utterly unaffordable. We may even be there already. How did we get here? Well, in some ways, we're a product of our own success. The fundamental issue is this: people are living longer and longer. The median life expectancy in Australia is now well over 80 years old and is continuing to climb. Sounds great, but the problem is, it turns out that there is a ceiling to how long a human being can actually live biologically, and that's around 115 years old. We have an expiry date, no matter what science fiction and health tech companies would have you believe. So, as we keep increasing people's ages to try and reach this upper limit, the more and more difficult, and therefore the more and more expensive it gets. Partly because we're fighting a losing battle against biology, but also because we need to sustain and maintain the ever-aging population that continue to use healthcare resources while they're alive. It's like climbing a mountain that gets steeper the higher you climb. So what should we do? Well, the first thing I'll say is this. Don't freak out. There is hope, but it does require participation by each and every one of us. Also, like all difficult problems and all awesome TED Talks, we need a three-point plan. And I've prepared one earlier just for today. So here we go. Point number one. Select a system. Select a system. There are two basic ways to pay for healthcare: a shared public system, where we fund free healthcare for everyone through taxes, and a private system, where each person...
Sorry about that, folks. That actually some technical issue that I'll try to figure out what it was later. But you get the point. He was basically saying that with all the advances in technology and the ever increasing emphasis on these things, we're developing more and more and more things we can do. We're not working to find ways to efficiently distribute those to the population. So I'm going to wrap up real quickly with a couple of videos here. One of which is by this author, reporter, Mary Otto. Mary Otto really got interested in healthcare. She's not a dentist. She got interested in healthcare because of her association with the story of Diamante Driver, who was a 12-year-old covered by Medicaid in Maryland and died because he had decay in a permanent molar and couldn't get it taken care of quickly enough, and it spread to his brain. And despite ED visits and despite surgery ultimately on his brain, he died. And that really got Mary Otto involved in oral health care. And she actually has written a book that talks about the history of dentistry, et cetera. So You could look at that. But let's listen real quickly to 3 minutes of what Mary has to say here.
You know, a third of Americans lack access to the most routine kinds of preventive care. So inequality in dental care and access to care really reflect our deepest social and economic divides here in this country. What we have today is a separate system of not only educating dentists and physicians, but paying for medical care, financing it, researching, even coding. You know, our heads are attached to our bodies, but our medical records and our dental records are not kept in one place. The codes are not even fully compatible. So our healthcare system doesn't reflect the fact that our oral health is integral to our overall health. The two huge federal programs that provide health care benefits to millions of poor and older Americans, Medicaid and Medicare, treat dental benefits separately and differently. It's the poor and the elderly and people of minority groups are bearing a disproportionate burden of this epidemic, and it's real. People who lack routine dental care can end up with severe consequences. Diamante driver, he suffered from the consequences of untreated tooth decay. He came home from school with a headache one day in January of 2007, and he didn't feel well. He was an active little boy, and his grandmother was worried about him. She took him to a small community hospital where he was diagnosed with an abscessed tooth and a sinus infection, and he got some medicine and went home, but he just got much worse. Doctors told his mother that bacteria from this infected tooth had spread to his brain. He was fighting for his life. Diamante stayed in the hospital for about 6 weeks, and I checked in with Mrs. Driver, and she told me, devastated, that he died. And it turned out Diamante was one of like roughly 1/3 of Americans who experienced significant barriers getting access to routine dental care. So it's a big problem, and yet it's kind of escaped the notice of the other 2/3 of Americans who have access to the private practice system that offers most of our dental care in this country.
Yeah, so that's Mary's story, and then I want to wrap up with this story of another dentist who's had a varied career. I don't know this person, I don't know of them, can't vouch for every statement that she makes in this video as being true, but I want you to listen just quickly to the way that she is talking about the need to change the way we do things. And I'll have to use the same trick that I know many of you use to speed this up. Sorry.
My love affair with teeth started in 1971. Although I'd wanted to be a medical doctor, not a tooth doctor, I fell in love with the beauty of teeth, the elegance of their lines, and how cleverly they marry form to function. At times, though, like a capricious lover, teeth would make my life so utterly miserable that I threatened to leave the relationship, quit dentistry. But then, a beaming child whose smile I'd just restored would have me fall in love all over again. Today, still smitten, I'm here to share teeth's secret purpose, to be the sentinels of our body. Teeth are amazing engineering marvels with features and edges like no other body parts. Their unique structure has even been copied by the race car industry to enhance performance and safety. With enamel more than 2.5 times harder than bones, teeth are designed to last a lifetime, decades. But unlike bones and all other body parts, when diseased or injured, teeth don't heal. My bold hypothesis is that this seemingly unfortunate disadvantage for oral health is actually an advantage for overall health. To analyze this proposition, we must first examine two major trends that unfolded during the second half of the 20th century. Fluoride in your drinking water to prevent tooth decay, and low-fat foods to prevent heart disease. How well are these two strategies working now? Well, the demand for dentists is increasing more rapidly than the demand for all other occupations. And heart disease is the #1 cause of death, both for men and women. In 1951, water fluoridation became policy in the United States, a policy that proved so successful at preventing tooth decay that in December 1983, the New York Times reported a public health expert's prediction that tooth decay in children and young adults would be gone by the turn of the century. Yep. These experts didn't know that a trade group calling itself the Sugar Research Foundation had meddled with science. In 2015, dentist turned researcher Kristen Kearns exposed documents dating back to the 60s, proving that the Sugar Research Foundation paid Harvard University nutritionists to counter science linking sugar to coronary heart disease and to instead recommend a dietary reduction in fat and cholesterol intake. This gave birth to the 70s low-fat diets and processed foods, touted to prevent heart disease and promote weight loss. But low fat means low flavor, a problem food manufacturers quickly solved with the addition of more and more sugar, which has since been proven more addictive than cocaine. Meanwhile, dentistry entered an era of exciting and distracting changes. There appeared white composite fillings, so much nicer than silver amalgams. Implants enabled dentists to restore function like never before. Adhesives and new porcelains to restore teeth to their natural beauty. The work of a dentist no longer was only about drilling and filling decaying teeth. I could actually make someone's life better with my dentistry. And I did. And it felt good. I was also learning that teeth are terribly fickle. Remember what I pointed out earlier? Teeth don't heal? Well, that means fillings fail. A lesson all dentists are reminded of throughout their careers. Like thousands of other dentists, my approach to failing fillings was to take more continuing education courses. I prided myself for being at the leading edge of my profession. But while my colleagues and I were learning everything new and better in dentistry, our gains against tooth decay plateaued, and eventually the rates of tooth decay started going up again, despite the increasing number of communities fluoridating their water and the widespread use of fluoridated toothpaste and mouthwash. Nevertheless, we pushed for more fluoride, and guess what? In October 1999, the Center for Disease Control named community water fluoridation one of the top 10 public health achievements of the 20th century. We celebrated! But does tooth decay happen because there's not enough fluoride in the water? Or could it be that tooth decay happens because there's too much sugar in our diets? Now that 74% of the United States population has access to fluoridated water, why then is tooth decay still the #1 childhood disease, 4 times more common than asthma, when it was supposed to be completely gone now? More troubling is the corresponding data that since sugar has found its way into every single aisle of our grocery store, there has been an alarming increase in the rates of obesity, diabetes, and non-alcoholic fatty liver diseases in children. In children. And the obligation to treat these diet-related diseases falls upon family physicians and pediatricians, while dentists focus on the other diet-related disease, tooth decay, separately. We've got to stop this right now. Since when are teeth separate from the rest of the body? Not once in my whole career have I seen a set of teeth walk into my office without their human owner. Although at times my job would have been so much easier, you know. No brains, no opinions. But now let's talk about you. When you take your teeth to your dentist, what problems are you hoping to solve or avoid? How different are the concerns you bring into your physician's office from the concerns you bring into your dentist's office? Do you ever talk about your teeth with your physician? Perhaps you should. And here's the most important reason why. Your teeth are the best, the most accessible, the most obvious early warning system for predicting future breakdowns elsewhere in the body decades before they occur. Now, how about transforming a dental visit into a whole health advantage? Imagine for a moment your child's dentist, after finding some white spots on a few teeth, not even full-blown tooth decay yet, with genuine concern for your child's health, prompts you and a dental medical team to troubleshoot why enamel, the hardest tissue in your child's whole body, is breaking down, thus leading to the interception of not only full-blown tooth decay, but also other diet-related diseases before they manifest. You see, your child's liver, heart, pancreas, with their capacity to heal, can cope much longer than teeth, not forever, but longer than teeth, with the stresses of a toxic diet. This means that an early intervention triggered by teeth can actually prevent permanent damage to other organs and tissues in the body. According to Hippocrates, the best medicine is to teach people how to not need it. Addressing the population's essential needs for oral health education will do more to improve overall health than enrolling more people in health insurance programs or removing barriers to healthcare as we currently know it. Because health begins right here. Our bodies are so much more than a sophisticated aggregate of separate functioning parts.
So I'm going to stop there. Obviously, you'll be able to listen to the rest of about 5 minutes of that video another time. I know you're going to get off to other classes. Just want to wind up by saying, the real purpose of the course is to help you understand there is a bigger picture out there. It's dynamic, it's changing, and as maybe help you think about all this other kind of basic science and other types of information you're getting along the way, as well as your dental education. So with that, we'll wind it up. Say thank you. It's been great, even under these circumstances. Having this course, try to change it up every year or make it improve it. Your feedback in that is very helpful, so please do. And I look forward to finding out someday down the road that many of you have been involved in actually not only providing great individualized dental care, but helping to change the system and improve the system in which you're going to work for the rest of your professional careers. So be safe out there, take care, and happy holidays to everyone. Thank you.